Well, good morning, everyone. Hello to all of you. We're broadcasting live from the Eastern United States. It's 7 a.m. here, and we welcome all of you around the globe. Good morning, good afternoon, good evening, good night. We have a great turnout this morning as well. And the topic, of course, is about enhancing medication error reporting programs to improve global medication safety, but local medication safety as well. Practitioner reporting programs are an important way to learn about potential safety risks in the medication use process. Learning from reporting errors and subsequent analysis is critical if improvements in care are to be achieved. But the value of reporting medication errors within healthcare organizations is often limited by the cumbersome and time-consuming nature of internal error reporting methods, punitive cultures, and the lack of methodology to analyze our data. My name is Mike Cohen. I'm president of the Institute for Safe Medication Practices, and I'm going to introduce our speaker today, Matt Grissinger, in just a few minutes. But the webinar today is designed to assist organizations worldwide in improving their internal reporting programs. Our speaker will discuss the importance of gathering key information as well as the value of applying ISMP's system-based approach to error analysis. Also, the negative impact that punitive systems and poor feedback mechanisms have on our reporting and our reduction efforts will be addressed by Matt. Participants will also learn how to identify medication safety risk beyond the use of our reporting. So let me introduce Matt Grissinger. He is with us at ISMP. He's director of our reporting programs at the Institute for Safe Medication Practices. He's a pharmacist. He first joined ISMP in 2000 as an ISMP Safe Medication Management Fellow, and then he stayed on after his one-year fellowship. His responsibilities include working with healthcare practitioners and institutions to provide education about medication errors and their prevention, and reviewing medication errors that have been voluntarily submitted by practitioners to the ISMP National Medication Errors Reporting Program here in the United States. Prior to joining ISMP, Matt served as a home care and long-term care pharmacy surveyor for the Joint Commission. He has served as chair of the National Coordinating Council on Medication Error Reporting and Prevention. Some know that as NCMERP. And he's vice chair of the National Quality Forum, NQF, Common Formats Expert Panel. He's also an adjunct assistant professor for Temple University School of Pharmacy, which is in the Philadelphia area in the United States, and he teaches a course there in risk management. So welcome, Matt. There will be questions and answers at the end. I wanted to let people know to hit the Q&A button at the bottom of the screen should you have any questions, and we'll reserve some time at the end for Matt to answer your questions. May not get to all of them, in which case we'll figure out a way to get the information to you, probably through our website. I wanted to say that we greatly appreciate Novartis Pharmaceuticals Corporation, in particular their name creation and regulatory strategy department, for supporting this program. They truly do that altruistically. There's nothing that they gain from the marketing standpoint for supporting these programs, which enable us to do them and get the information to you without any charge. So we greatly appreciate that. And with that, I'm going to turn the program over to Matt Grissinger. Matt?
All right, thanks, Mike. Good morning, afternoon, evening, everybody, and thank you for taking time in your busy schedule to listen to the webinar today. As you see on the title of the slide, we're going to talk about your error reporting, incident reporting programs within your organizations or across systems. And the second slide, we'll see some objectives here. We're going to talk about reasons why healthcare practitioners may be reluctant to report errors. We'll show how the underreporting of errors, as well as a lack of thorough investigation, probably prevents system improvements where you work, and it also inhibits your reporting program as well. But also talk about other ways to identify risk and collect data about medication safety in addition to error reporting as well. So if you wouldn't mind, for those who are up this time of day, I also have the chat box open. So if you want to submit comments, I can see how people are reacting to the presentation. So not the Q&A box this morning, but let's do the chat for me now, and then we'll do questions and answers later. So you've seen the slide I have on here. In order to convince staff to report, we need to know what. So why are we reporting, or why do we have incident or error reporting programs? And I'll give people a couple seconds here. Can you put in the chat box, why do you expect people in your organization to report errors? Or say you hire me to work for you, wherever you may be in the world, and what are you going to tell me as a new hire? Why do you want me reporting errors to you? And Victoria came in and said, to learn and prevent future errors. Linda says to improve with safety. Sheldon, to look for trends. Shelley, identify problem stuff. Joe, capture near misses. So yeah, a lot of good answers coming in here. Prevent irreversible harm. Beth has documentation purposes as well. Prioritize safety from Emily. So yeah, quite a few good answers in this slide. But let's go to the next slide here, though. So many people will respond to answers like this. Well, why do we have reporting programs? And people give me answers like we've had in the chat box. Well, we're going to learn why errors are occurring. Or we're going to identify trends in our organization that some people have cited, or possibly to determine how well are we doing. So my next question for you is this happening now in your organization? Yes or no? Right now, you just gave me all these reasons why we have reporting programs. But is this happening? Are you learning about errors that are occurring, identifying trends, and et cetera? And we got some yeses, quite common, et cetera. So we have some yeses. Okay, and I anticipate some. We have not often, we have some. So the answers that are coming in, they're kind of mostly yeses, but definitely some nos as well. Okay, so despite, and I'm not going to argue with what everyone submitted regarding why you have reporting programs, because yeah, we want to try to learn why errors are occurring, but I'm going to come back to that because I don't believe we are finding out why errors are occurring. Identify trends, we'll talk about that subject later as well. And we'll also touch the topic of determining how well we are doing. I think, but one basic ground rule I think we need to understand of overall, and yeah, we want reporting programs to learn about what's going on in our organization, but there's also, I think, in my mind, a higher level reasoning why we have reporting programs. And that is to support the culture that you have. You think about this, how many different ways do your staff currently make you aware of problems, potential problems, concerns, or actual errors? And that's the reporting program. But it's also the way that, in the second bullet, that gives people an opportunity to be a contributor to improvement. So it's a very big communication tool. It's the one way that all of your staff can communicate with you about safety issues. Okay, so really the reporting program, we'll come back to this culture theme a lot in the next couple of slides. But a great reporting program will support a great culture. A poor culture in your organization will probably result in a poor reporting program. So they go hand in hand. So I want to make sure we stress that. Yeah, although we want to learn about active failures, we have to document the event. It's really a way for us to hear our staff's concerns. And that's number one. And when we have that open communication, then people will report to you, and then you may learn about errors. But that open culture and wanting to learn from our staff about what is wrong is the number one priority of reporting programs. And if you have that as your first priority, then everything else should flow in nicely. But lastly, we're going to talk later. One thing about reporting programs is it's not really a good way to collect quantitative data or trends. And we'll touch on that theme a little bit later as well. And so throughout this presentation, I'm going to talk about the good and the bad about reporting programs, just so we understand what reporting programs really do or really do not do. Okay, so let's start with some things that it can do first. So yeah, it can identify local system hazards, and this first sub-bullet is extremely important, especially how ISMP looks at reports. ISMP does not wait for 10 reports to come in to write an article or newsletter. It can be one single report that proves you have a major problem. So I'll make sure we understand the concept, because I know at times we're worried about trends, but one report about a serious event with a neuromuscular blocker or an opioid can really give you a lot of insight to the problem versus waiting for 10 reports of the same thing. Now, it's nice to have some tools to do an analytic, systematic review of the error, and there's a form on our site called the Assess Error Form, which uses ISMP's 10 key elements as a way to help us with that. So getting one report's nice, but you still have to follow up and investigate it. One report will rarely tell you everything that went wrong in that case. Reporting programs can also give people with large data sets, like I'm thinking patient safety organizations in the United States, or maybe other ministries of health throughout the world who collect errors throughout the country. You may be able to get aggregate experiences of uncommon things. So not common things of, well, how many wrong drug errors do we have, but more specifically, how many errors have we had with neuromuscular blockers in our perioperative area? How many errors do we have with antibiotics in our medical surgical area, but from a large aggregate perspective? I don't think this works well in one hospital, because it depends on the size of the hospital. I'm not sure how many reports you get in a month that are about specific issues. So, but it comes across a patient safety organization in the United States has contracts with many hospitals, and they can get multiple hospitals reporting to one local reporting program. Now you're talking about hundreds of thousands of reports coming in, which is different than what you may get in a single reporting environment in a hospital. Reporting systems can also, again, improve your culture. And really, how you handle your reporting, how you handle your staff who report errors, and how you treat them is a reflection of your culture. And if you treat them with using a just culture approach and with shared accountability, you're going to have a good reporting program, because you're going to have people buying into wanting to tell you what the problem is. So again, around the world, this has got to be a huge undertaking first. And really, the communication that takes place, and we'll come back to this at the end about having good communication. And reporting systems can help you share lessons learned within your organization, across a health system in the US, across the country, or across the Ministry of Healths around the world. So lessons learned can help prevent similar events. So like ISMP's newsletters, we get one report in, we write about it, put a NAN alert out about what we had this past week, and then we're sharing what we learned from a case or 2-3 cases to you around the world. So can you do the same thing in your organization? Can you take one report and learn from that and share that with staff? And that, again, sharing with staff will improve that culture. Of course, using external use of sources of information like ISMPs, but don't fall prey to this last bullet. And we get frustrated when we've reported things, we've written about things, and clearly there's organizations who read our newsletter and say, oh, what can never happen here? Wow, did you read that report ISMP wrote about? Oh, that was terrible. Oh, that can never happen here. So having that type of attitude will only hurt you versus learning from single events across organizations or from ISMP. So, okay, yeah, that's all well and good, nice. But let me ask you in chat box, simple yes or no question. Where you work, do you think that everybody is reporting everything that could possibly be reported? So I'm not saying what your policy says, I'm talking about the real world. Is everybody submitting everything? And the no's are flying by the screen here so fast I can't even read the names. But lots of no's, lack of time, yeah, tons of no's. So clearly, so everyone, keep that in mind. Nobody said yes to this question, because I'm going to come back to that theme. We'll talk about measuring error rates. So next response is in the chat box. Why does that same event keep happening? Or why aren't people reporting errors? And we have time constraints. People are afraid of telling others in the chat box. The staff perceive that reporting is punitive. Error fatigue, or probably reporting fatigue, right? Fear of punishment again. Becky has, they don't know an error even happened. It's not easy to report from Mary Ann. Complicated reporting systems from Maria. So you guys just gave like the next couple slides of my presentation with all your answers. Thank you for all the feedback in here. I see Rabbi's in here. He's not fixing the problem, that people report things, but nothing's getting fixed. So all good things. So everyone, just keep that all in mind, because you guys have tons of reasons why people aren't reporting here, right? So we'll come back to that theme in a second. Thank you, by the way, for the participation in the chat box here, by the way. So let's go over some limitations of reporting programs, because my end goal of this is not to say air reporting programs are bad, but I want everyone to deal with the reality of what you do get from a reporting program and what you don't get from a reporting program. So it's really important with how you view this program. What's the goal of this thing at the end of the day? So the first limitation is, I'm sure most of you rarely get in-depth analysis from a report, or oftentimes all the reports you get in don't result in a strong strategy, okay? And so why aren't we getting an in-depth analysis? Well, part of it is we're expecting the frontline staff to fill out this entire form. So like the bottom bullets, right now, many people have a form, paper, electronic, and it's up to that frontline nurse to fill out the whole form. But to the first bullet, what does staff really know? Like, when it comes to fill out a form, what knowledge base do they have to successfully fill out every item in that form, including if you expect them to pick contributing factors? How would they know that? You have a frontline pharmacist or frontline nurse who's just busy getting work done that day, who barely have time to report. So now you want them to stop to fill out a report, which we talk about the lack of time to report. And I would make the argument that I think we may have time to report, but the problem with this third bullet is the form that you use can be so long. And I have it here, I'm calling it inappropriately designed form, meaning you're asking too many questions of the frontline staff. What would a frontline nurse really know to fill out that report in 1 minute? Think about a 1-minute form, everyone, right? There's times I've asked this question to audiences and I ask, hey, how long does it take to fill out an air report where you work? And people come back and tell me 10 minutes, 15 minutes. Who's going to stop their work to fill out a 10-minute form, everyone? Nobody is going to stop their work to fill out a 10-minute form. So the length of time, and so I would make the argument it's not the lack of time, it's the length of time to fill out the report is the problem, when really you only want a couple questions to get the ball rolling to start an investigation by somebody else. And so in addition to that, then this first sub-bullet, especially depending on how many reports you get, this information that you get from a report is honestly superficial. And I'll have that on the next slide as well. So what you get from a frontline staff is not a story. It's usually a sentence or two, and that doesn't help anybody. And therefore, when you get a sentence or two, or you're really doing analysis and following up, and I'll show you an example in the next slide about that. But keep in mind, superficial analysis equals no meaningful change, right? You can't make meaningful change if you don't know the root causes of the error or contributing factors of the error, right? So in addition to that, no meaningful change means that the majority of the change to the staff means education and training. So keep in mind, from our viewpoint, you get a report in, and your response is, well, I'm going to educate the staff, I'm going to hang a poster and give a presentation on this error. And those are all nice to do, but they don't have long-lasting changes. That's why it's a low-level strategy. Once you present it today to educate everyone today, they're going to probably forget about it next week. So what real changes are happening? Forcing functions, hard stops, independent double checks, using your automation to its fullest capacity with decision support. Keeping in mind, so superficial analysis means no meaningful change. No meaningful change means there's no value to a reporting program. If people are reporting to you and their perception is, I've reported all these errors, but nothing's changed. So who's going to report something if they perceive that nothing's changing? So there's kind of all comes back together here. Another limitation for some people, you get too many reports. right? I know people maybe are listening in who get hundreds of reports a month. There's just no way you can fall below that. And these two examples apply to getting too many or too few reports. But when you get reports that say, well, nurse gave the wrong drug, or the pharmacist dispensed the wrong dose, these don't help anybody. These two sentences don't mean anything. It means nurse gave the wrong drug. But when it comes to taking action, what action am I going to take here? I don't know the circumstances. If there are issues with interruption, problems with the environment, problems with the package labeling of the drug, problem with the name of the drug, or how the name was displayed on a medication administration record. There's a lot of reasons why there are wrong drug errors. So just putting that in doesn't help anyone. So in addition to the incompleteness, who has time to read all the reports? And I'm not insinuating you read all the reports, by the way. I don't know if that's a good use of all of your time. But keeping in mind the reality of getting a lot of reports, they're short, there's not many words in them. They don't provide a lot of data about the medication use system. They may provide data about active failures by the frontline staff who misread a label. But what about the system that contributed to the problem? Why did a pharmacist dispense the wrong dose? What contributed to the problem or caused the problem of misreading the dose? So error reporting rarely tells you about the system. It'll tell you about the individual, but investigations will tell you about the system. Do people here have issues where the reporting program is used to complain about people? Right? And a reporting program from some people is nurses complain about pharmacists, pharmacists complain about nurses. That's not the point of a reporting program either. So that's not helpful. And again, I'll stress again, dissatisfaction from users when nothing's changed. I see comments back here from Rabi like, yeah, it's complaining all the time because if pharmacy has issues getting drug out the door, the report will be, my drug was late all the time. And that's nice getting reports, but we still have to address the root cause of why there were the delays. So thanks, Rabi, for adding that in the chat box. All right, so next slide. So the third limitation to reporting programs is this: you can't use it to measure anything. I mean, you can use it to measure something, but you cannot use it to measure safety. If I'm correct, so the reason you can't measure safety is, well, you already admitted events are underreported. Everyone said here, no one gets all the reports, right? So how can you measure something if you know you're not getting all the reports? Right? So, and we're going to come back to really what is the number you're reporting back. So there's no such thing as an error rate. There is a such thing as an error rate, not with error reporting programs though. You can't measure errors with reporting programs if you're not getting all the reports. And then so we say they're underreported. Why they're underreported? Well, you gave me most of the answers. I can fly through here. But other additional ones is, well, what's reportable? What's the roles where you work? Is for Rabi at Cleveland Clinic in Abu Dhabi, they may define what's reportable compared to what Gadir has in Riyadh, Saudi Arabia. So the definition of what is reportable, is it everything? Is it only harmful events? Is it close calls? Is it concerns? So that changes everything, especially when you have a reporting program that encourages reporting of potential problems, near misses. All of a sudden, you try to start measuring things. Well, you're really measuring a great buy-in to reporting near misses, not error rates. It's a total different measure. Other problems for underreporting: lack of time. Some people report with regularity, some don't. I know when we worked in Pennsylvania with the state reporting program, I can tell you in Pennsylvania, nurses must have filled out 80% of the reports in Pennsylvania. There's no prescribers, very few pharmacists. If pharmacists fix things, they don't report things. And the nurses are just telling on each other at the end of the day. And that gives you a misperception of what's really happening in the organization when nurses do all the reporting and everyone thinks, well, nursing's the problem. Well, no, nursing's reporting because they have problems they want to share, so it should be used in a positive way. Lack of feedback to staff. What's your staff's perception about your reporting program? Have you asked what your staff thought about your reporting program? First thing you do when you leave here today, do a survey of your culture where you work and ask people, are you afraid to report errors here? Or why don't you report error or close calls to us, and see what they say. Because of the feedback that you may get may not be good. And Michael brings up a note, sometimes staff view reports as a black hole. Yeah, and so Michael, we're gonna come back to that because I agree. If staff thinks it's a black hole, then your reporting program is not doing very well. So let me go back here. So do not put this in the chat box. I'm gonna ask you a question to keep in your head. Think about the number of reports that you get where you work in a month. Please don't share it. Keep it yourself. How many reports do you see in a month where you work? Knowing that everyone on this call, over 500 people on this call, are going to have a different response, okay? The reason I'm saying that number is this. There's two studies in the next two slides saying, number one, in this study, less than 4% of all average drug events involving a use of a rescue drug were reported. So any event involving an opioid where they got naloxone, anticoagulant, they got protamine or vitamin K, less than 4% of those were reported. Another study showed that only 6% of average drug events were identified through traditional reporting programs. Next study. Another study shows that their reporting system detected only 5% of incidents that resulted in harm. And lastly, a report from the Office of the Attorney General in the US in 2008 showed that, this is based on interviews of hospital administrators, that they estimated that only 14% of the problems were captured by reporting programs. So think about that. But that reporting number you thought about in your head, how many reports you get in a month, at best, that may represent 14% of the real problems where you work. 14% at most. So that's an important thing to consider of what the reporting program is really telling you. Another limitation is you can't measure change. So you can't really measure errors because you're not getting all the error reports, right? So in addition to that, say you're using a reporting program to identify a problem and you make a change, right? So you made an improvement, you put some strategy in place. How do you know if that improved or not? How do you know things have gotten better, right? So, because keep in mind, an increase in reports may be due to an increase in reporting because people are buying into reporting, but the decrease in reporting could be, increased reporting could be people are buying into reporting now, or it could be there's a legitimate problem, but I don't know. On the other hand, the decrease may be typical. A decrease in reports could be just people are tired of reporting, or you're doing great. But those are two different answers that have two different conclusions of people are either not buying into reporting or you're doing well. I would always venture that you're always going to want to have an increase in reports. The goal today is to get more reports. I know it doesn't sound that way in my webinar, but we do want more reports. I want you to deal with the reality of what you're going to do with all those reports. And of course, you can't compare organizations. It might come put the link into the NCCMERP into the chat box that goes over the statement of why you should not use medication error rates based on error reporting is the key thing here. You could technically do a study measuring error reports with observation, but we're not talking about today. We're talking about reporting programs that don't identify everything. So really, is there such a thing as a national medication error rate? You used to get that question at ISMP, and I don't think we get as much anymore, but is there such thing as a national US error reporting rate? And the big answer is, no, there's no such thing as a national reporting rate. There never will be anyone. There's never going to be a national European error rate or a Southeast Asia error rate in Malaysia as an example, because you already told me not getting all the reports. So don't even go down the path of measuring a rate. Keep in mind, a rate is a numerator and denominator. So the numerator is number of error reports received. But you told me you don't get all the error reports. So what are you measuring? So keep in mind, never use error reporting as a way to measure a rate of how good or how bad you're doing, because you're not getting everything. And if you can't get a reliable error rate, you can't benchmark. Benchmark meaning you can't compare your hospital with another hospital in England or Ireland as an example, because Again, you can't measure an error rate. One thing to keep in mind here, I meant to underline this. If people are calculating an error rate, what you're actually capturing is an error reporting rate here. Like, I'm gonna break up my fancy pen here. You're calculating an error reporting rate, not an error rate. And that's okay to calculate a reporting rate. Just make sure you're not calling it an error rate because it's not an error rate. And lastly, think about aggregate data. So you see that a report's like this. I'm sure everyone on the phone has had a bar graph like this where they work, right? And look at my wrong doses and my wrong drug errors and wrong patient errors. But what is this data really telling you at the end of the day? I would struggle to say, tell me we have a lot of reports in April. People reported more here, few reports over here of wrong patients. But it's not telling us, well, why are there so many wrong dose errors? Why are there so many wrong drug errors? Keeping in mind, when we talk about wrong drug errors here, say in May, we have 26 wrong drug errors. But what's a wrong drug error, right? Wrong drug error could be nurse giving the wrong tablet, nurse giving the wrong IV, pharmacist dispensing the wrong capsule, pharmacy technician pulled the wrong drug off the shelf, prescriber entered the wrong drug in order entry systems, right? There's a lot of wrong drug errors. So what's this 26 really mean? Is it one of everything, as an example? So keep in mind, these are probably nice to show on a screen in your med safety committee, quality committees around the world, but this is not telling you anything. Just keep that in mind. It's telling you what's reported in that sense. So be careful of conclusions you make, because if there's no investigations, we don't know what's going on. All right, question for the chat box, everyone. What, in your opinion, not based on reports per se, but what drug classes cause the most harm in your organization? I have anticoagulants from Macy, insulin from Macy, blood thinners, hypoglycemics, analgesics from Mohammed, opioids from Haley, and pretty interesting here. See a contrast in here, vasopressors. So it's interesting, everyone, reading off the chat box here, and the overall theme appears to be insulin, opioid analgesics, and anticoagulants overall, everyone. Okay, so let me ask another question. Did you need an error report to tell you about these problems? Did you already know these problems exist without a reporting program? So I'm getting all these no's, maybe not some yeses, but many times you give these answers because you know you have the problem without a single report coming in. So what numbers, how many reports are you waiting for about anticoagulants to make change? Why? If you know now there's problems with these drugs, what the change can be made now. Having a report come in is not going to change anything. So I would even make the argument that you already know the problems where you work. And having 10 reports about an opioid shouldn't change anything. You know now there's a problem with opioids. You know now there's a problem with anticoagulants. So that's why I asked that question. You already know the answers. So waiting for another report to come in is not going to all of a sudden change the world for you. And really, what does aggregate data really mean? So it shows interesting trends in quotes, but is that really a reporting trend or an event trend? All of a sudden, I have more wrong drug errors reported this month. Is that just because by coincidence, people reported wrong drug errors? Or is there legitimately a problem with a specific drug causing a problem? Those are two different answers. So be careful how you use the word trend, because the trend could be a reporting trend, not necessarily it's a problem trend. So I hope I'm making sense. There's two different types of trends here. It's really about the reporting trend that you're really seeing more than actually something going wrong. There's not a lot of detail to work with in reports, everyone. And in fact, the cause may be unclear, but most importantly, at the very bottom, from our experience, and based on what ISMP does with our reporting program, by far, the most important field in any error reporting program, incident reporting program, is this bottom bullet, is the event description. You need to allow people to type as much as they can to tell you what happened, and let them tell you the story. If you've read an ISP newsletter, whether it's a safety brief or a main article, the stories you read come from reporters telling us the stories to our reporting program. And in a way, them telling us the story without filling out these other forms and other check boxes and drop down boxes, just tell us what happened. I'm telling you, you'll get a lot of information in the event description. Now, it's not easy because you have to do some coding later, but the contributing factors like Bindu is raising in the chat box, you may get those in the event description, but more, you'll definitely get specifically what happened. I'm not convinced you get why it happened, and we'll talk about that later as well. I would tell you, based on our experience looking at aggregate data of error reports, that error reporting programs in hospitals and big data dumps will not tell you why errors happen. So I'll make sure people have heard that correctly. Error reporting from an aggregate perspective will not tell you why the event happened. It won't tell you why because you're not doing an investigation after every report. You're not doing a root cause analysis with every report to figure out all the contributing factors, all the reasons why the error happened, like using ISMP's 10 key elements. But it will help you give you more specifics of what happened, and that's still very useful, everyone, to find out the details of what specifically happened. But to get your contributing factors requires investigation. So why do people report to ISMP? And you're probably wondering, why is this in here for this presentation? So number one, and I think Mike would agree with me on this, but people report to ISMP because they think it's the right thing to do, right? They know if they report to ISMP, we're going to promote change, make people aware of the problem, give feedback on product changes. We don't reveal people's identities, but people know if they report to us, we're going to try to do something about it. So why can't that apply to you? Why can't people report to you within your country, within your Ministry of Health, within your hospital system, because they want to do it? So when we come back to culture again, everyone, people have to want to report to you. You have to have that culture. If you don't have the leadership of kind of the concepts of a high reliability organization, always looking for risk, knowing there's always errors happening and expecting that, having an open culture will lead to better reporting programs. So culture and reporting are hand in hand. You have to establish a way that people buy in to reporting to you because they know something's going to happen. It's not going to go in a black hole. They know that you're going to try to make a change. Now, you're not going to make a change with every report coming in. So don't think that every report requires an action, but also communicate that with staff. And we'll come back to that in another slide here. So let's talk about strategies to improve reporting for all of you. So number one is this: it has to be easy to report. Anyone who texted me earlier in the chat box that took too long to fill out a report, guess what? Then you got to address the problem of why it takes too long to report. I would suggest it's got to be very quick and easy to access the reporting mechanism, easy to find. 1-2 clicks, I'm in it. I shouldn't have to click 10 times to find it. I shouldn't have to click 10 things to report an event. Really, it shouldn't require a lot of training to figure out how to report something. Right? And lastly, limit the number of questions. The fewer the questions, the more reports you'll get. Right? Now, it's kind of contradictory for you. You're probably thinking, oh, God, Matt, but I want these questions answered, right? Okay, well, what do you want? Do you want good reports with meaningful information in the event description, or you want a lot of check boxes filled out? You can't have both. So some check boxes, okay, it's got to be simple, but it's got to be something, again, the goal has to be 1 to 2 minutes to fill out a report. Whatever gets you to that goal as well. And Marianne also has on here, giving feedback after the report. Thanks, Marianne. That's a very good point. So part of the reporting program is going to be about communication. I'm going to come back to that in about 2 slides. You know, make reporting meaningful to the reporter. You know, why would they want to report to you? So it's important that you obviously address some of the reports and put good strategies in place. Now, keep in mind, again, you're not going to fix everything for every report. So don't think every report that comes in, I have to fix something. It's just not realistic, because a real system change takes time. Educating staff doesn't take time. Hanging a poster doesn't take time. Emailing staff doesn't take time. It's nice to do, but you need other steps. But also, I think it came back again what Marianne said, is that feedback, though. So you have to make your staff appreciate the reality that you're not going to be able to speak to 500 people who submitted a report this month, but at least make sure there's always open communication about what you're getting in. Think about ISMP's newsletter, right? Can you do something like that in your organization based on your reports? De-identify them, don't criticize anybody, thank people for reporting, say, hey, Rabi sent me this report the other day about the situation, tell the story, and so what we've done is we made these changes where we work, and put that in a newsletter. So people then know that, oh, look, we got a report, did something about that report. So that communication is very key. It's not just, so that culture of open communication of wanting to get information from the staff to me to learn, but also back out to the staff to say, hey, thanks a lot we had X number of reports this past month. That's fantastic. Here are some key things we're going to do to fix some problems that were commonly reported. So that communication is very, very key, so people realize that. And back to the beginning slides. Promote the concept that each employee is an important contributor to improvements. If people feel like they are having an impact where they work, they'll report. If they feel like my report's going to a black hole and nothing ever gets done, why am I reporting for? It takes too long, nothing's going to happen. So that underlying culture has to change. More reports equals better culture at the end of the day. Provide feedback again. Keeping in mind, the staff has to be aware you can't provide personal feedback to everybody all the time, okay? But there's got to be some sort of way of getting back the feedback to staff in some way beyond email, that they realize that, yes, it's important you sent this in. I may not do anything about it now, but I may come back to that in a couple months because it may prove we have a bigger problem somewhere. Share reports with staff. De-identify them if you can, as long as the reports are used to share why it went wrong and what we're doing to prevent this from happening again, or detect the error again as well. Third bullet, very important, any leader on the phone here, very important. You got to devote resources to not just collecting them, but also analyzing the reports, but more importantly, putting strategies in place, right? At the end of the day, we want to mediate risk by putting good strategies in place. So leaders have to understand that a reporting program alone doesn't do anything. Having a reporting program and that's it means nothing to me at all. If you have people who know what to do with the data, to do some investigations, and also work with leaders to put in strategies, the reporting program is not going to really do much. Again, if staff see you make change based on their feedback, real changes in culture will happen. You notice this culture thing again coming up? You have easy reporting, people buy into reporting, they see you make changes to reporting, they report more to you. You ask Mike here at the end, there's people who report to ISMP because they reported to us, their story got into the newsletter, they're going to report to us again. So that positive feedback, knowing all of us on this phone want to feel like we're making a difference. How can you make your staff feel like they're making a difference? More communication stuff. Instead of measuring the number of events coming in or reports coming in, how about measuring the number of successful system changes? No more, so let's go to the dashboard or report to a committee, we got X number of reports this month. Also include, well, here's the number of changes we made as well. And so, yeah, Golem has in here, well, what is the measure of success? And so really the measure of success is successful system changes. That shows that leadership's buying into it. They want to improve the medication system. They're listening to reports coming in. So those system changes are a reflection, again, of the reporting program and the culture and how you deal with that. So again, it's not the number of reports received. It doesn't matter how many reports you get in. You get 5 reports a month in, you could change the world, everyone. You get 5 reports in this month, could change your entire health medication use system. Depends what you do with those 5 reports, right? So that's what the key thing is. It's the really reducing the amount of harm, but not the reducing the number of error reports. Listen, you're gonna have to prioritize what to investigate. Okay, no doubt about that. You can't investigate all of them, so maybe it's high harm, high yield events. I would even make the argument, you guys have told me your concerns in chat box earlier, focus on those as an example for a certain time period. All right, so I have about 5 minutes to go and about 5 slides. Let me finish these up. But now, one thing I want to stress to close this webinar out is error reporting program is only one way to identify problems. So, in your work week, for those here, think about how much time you spend with your reporting program in a week. And is that all that time good use of your time? Okay, so I'm no way promoting you spend all of your time with error reporting activities in any way, shape, or form. I don't think that's a good use of your time because there's other ways to identify risk. There's many ways to detect potential for errors. There's many ways to detect actual errors in addition to a reporting program. Okay, so there's many sources of information. Asking your staff, your patients are a source of information. Technology and the reports that you get have sources of information about what went wrong. There's many different methods. I'll go over in the next slide, but you have to use many methods to identify risk where you work in addition to error reporting programs. So that could be checking out ISMP self-assessments on our website to proactively identify risk. Keeping in mind, error reporting is retrospective or after the fact reporting. The problem already happened. I'd rather have people report to me near misses or concerns, the proactive reporting of concerns versus errors. I mean, of course, you're going to report errors, but I'd rather hear people's concerns, number one. But why aren't you looking right now? Where you work, what type of self-assessments have you done in your organization to proactively look at unsafe practices? Error reporting probably won't tell you about the unsafe practice as much as you think. It'll show you the bad outcome for a process that didn't happen, but it tells you about one person in one moment of time. It doesn't tell you about your entire organization. A self-assessment makes you look at your entire organization for safety-related issues. Proactively doing a failure mode effects analysis when you put in new processes in place, reading external sources of data like ISMP's material from the Aggregate Institute on patient safety-related items. Also, pharmacy interventions, the pharmacy phone calls you make. Heba has safety huddles meetings is another great example she gave to us to identify problems. What about the pharmacy nursing phone calls? How are you tracking those? What's the most common phone call your pharmacist makes in a month? Keeping in mind, those pharmacy phone calls and those fixes don't get reported. And I'm not saying it should be in a reporting program, but this is a lot of data you're missing out on here. You have more pharmacy phone calls in a month than you'll ever have error reports in a year. So what are you doing with the pharmacy phone calls? Triggers, you measuring naloxone use, protamine use, vitamin K use, glucagon, dextrose 50%, IV epinephrine, IV diphenhydramine, all the drugs that you give when something goes wrong with another drug. That's another way to identify you may have a problem where you work. And then there's also retrospective stuff. This is where error reporting comes into play here, right? But keep in mind doing observation, walking around and looking around. What's going on? Actually observe nursing administration. Go to your operating room, observe how medications are used in your operating room. Observe how medications are being handled in the emergency department. Look around. We talk about different technology. Chart reviews, great, labor intensive, but great. So keep in mind, look at these last two slides, everyone. These are a lot of ways to identify risk in addition to error reporting programs. So keep that in mind. So in concluding on this, number one, you have to improve the culture where you work. If staff does not want to report to you, you're not going to get good information. Staff has to want to do that as well. Avoid collecting reports purely for the sake of counting things. I know I like to count things, but counting error reports to show buy-in that people love a reporting program is great. Using a reporting program to count errors is bad because you're not counting all the errors. You're not capturing all the errors. Third bullet, very important. One error report can be an indication you have a bigger problem. Think about how we do it here. We don't wait for 10 reports to come in, everyone. One report could change your entire medication use process and system based on one report. Think about that. It's not about the number of reports, because one can do the trick. Maybe it's that one report about insulin as an example. Be realistic about what you're getting and what it means. Please don't think that an error report tells you all the reasons why error happened. The only way you're going to find out why an error happened is doing like a root cause analysis, multiple day investigation, interviewing people, looking at where things happen, look at all the documentation, look at your electronic health record. That is real investigation. That's when you find out all the reasons why it happened. That's not going to happen in a reporting program due to time. So all I'm saying is, you're not going to do all that, be able to do all that investigation, but don't conclude that these reports are telling you all the reasons why they are happening. The reports are really telling you what happened at the sharp end of the nurse and the pharmacist handling the drug, or the doctor writing an order for the drug. And most importantly, consider a report as a starting point, not an end point. I always like to say, and one report is like a trigger to say you may have a bigger problem in your organization. So very important to understand that the report that comes in is not the end point. It's not, I got a report in, it's in a database, or I counted it, that's one. That doesn't do anyone any help. So on that note, I'm done. And Dr. Cohen, I guess you want to open the question and answer box for questions?
Thank you, Matt. Great job as always. Appreciate it. One thing we got a number of questions about is, are the slides going to be available, or is there a recording? And yes, there was a recording. Jordan Rufo handles that in. I don't know if Jordan is listening right now and can respond, but I know that we have recorded this. We are recording it right now, and I believe that will be made available. So we'll either send out a note or, look at our website for that area. But yes, we do intend to make that information available. There were some questions about error rates, and I know you talked about that, Matt. And people are concerned about the lack of usefulness of error rates. The experts that we talk with at ISMP and elsewhere. And Matt, you were the chair of the National Coordinating Council on Medication Error Reporting and Prevention. And I know they had a statement. Do you remember what that statement was about and where that would be available?
Yeah, and thanks, Mike. Mike had put that link in the chat box earlier as well and cited on there. But the reason, the rationale that even came out, everyone, was, organizations always had that desire to compare themselves with other people, right? And I get that, right? Am I better than you? Is my hospital better than yours? But the problem was people were basing that comparison on the number of reports you got in, meaning, well, Mike's hospital got 10 reports, but I only got 3 reports. So I'm better than Mike's hospital because I only got 3 reports. And now that's not a rate, but hence, if I have 3 reports, that's a lower reporting rate or error rate. And so that statement really came out and gave reasons why you can't compare yourselves against each other, Mike. So some of it is the fact that, listen, all hospitals are different. They all treat patients, but they all are different processes. Even within countries, within states in the United States, we're not all the same. And other things we went through before earlier, Mike, of why people don't report, lack of a standard definition, what's being reported. So there's a lot of issues earlier in the slides that dictates just why it's not good to use an error rate, and the NCC document kind of supports that position.
Yeah, I've always worried about, areas of the hospital that seem to have no errors.
Yeah.
We used to see that from the operating room, for example, but obviously there were occasionally errors. They just weren't reported anywhere because the people that work in the OR know each other very well. They work with each other every day.
Yeah.
And they settled the problem on their own, that at least they think they did.
Yeah,
but
Mike,
we really never had the benefit of, the expertise of a group of people that really are focused on error prevention and system enhancements to prevent errors. So that was always a problem. You could have a situation, Matt, I know you've talked about this, where, when you're even looking at nursing units, one nursing unit is, the manager might be more punitive than other nursing units that are doing a great job with reporting. And they just look terrible when they have a large number of errors compared to the unit where, you know, the culture of safety isn't what it should be.
Yeah.
So that's always been a problem, you know. Another thing, I saw this on the chat. No, I'm sorry, I believe it was, it might have been in the question box too, about the ratio of events that reach the patient versus near misses. In other words, which is more important for organizations to work on? Those that reach the patient or those that were reported but never really reached the patients? Or are they both important? In fact, just as important as one another, that category.
Yeah, Mike. Yeah, that's kind of a complicated answer too, because I have, I'll go back and forth because I will still believe, based on what we do at ISMP, Mike, is I think by far the most important thing is reporting concerns first. I mean, before it becomes a near miss, before it harms a patient, why aren't we asking staff, hey, what worries you about working here today? What worries you about using anticoagulants? And proactively asking those questions first. So I'm going to really promote that, because in some ways, I know we call these things error reporting programs, and it's probably wrong to use that term, because to me, it's really, what are your concerns reporting program? What almost went wrong reporting program, not error program. So yeah, I'm not worried about the ratio. And I'll tell you another reason, because it's based on reporting. And so I know, and Mike gave a good example of the OR or the ED that may have harmful events that were errors, but they don't get reported. So that ratio is okay. I would still say that, back to what I concluded with, using multiple sources of data, there are ways to measure harm. I would measure harm, just not based on error reports first. How much naloxone is being used for opioids as an example? So that, I don't know if there's the magic number ratio. Obviously, we want way more close calls, concerns than harmful events. And you think about it, if people are buying into your reporting program, you're going to get a lot of near miss reporting, which will overwhelm the number of harmful events you have. So really that ratio will go down because of buy-in to reporting the potential stuff versus the bad stuff. Now, I would say, not talking about numbers, of course, I want to investigate the harmful events. Those are good, golden opportunities to learn more what went wrong. But from a measuring standpoint, obviously, the better the reporting, the better the culture, the more near miss reporting you get, and hence that will determine that ratio at the end of the day.
Thanks, Matt. Here's one about, I'll just read it. How can I decrease the potential for intimidation of staff by pharmacy, well, I guess by leadership investigating errors? They're concerned that, somebody from the staff will be discouraged from reporting errors if, leadership comes in a few days after an event and starts interrogating the staff about the mistake that they made. What is the importance of communication back to staff after an investigation is made? How do they, wouldn't it be important for staff to know how something was handled? And do we always do, I don't know that we always do such a great job. I didn't know if you have any comments on that.
Yeah, Mike, I think, yeah, I get that. I can imagine when I do an investigation, the minute they see Matt in his white lab coat walking down the hall, people start running away because they know what I'm there for. So I think we might have to take a step back. I'm just curious about the culture, Jessica, where you work too, in a relationship between pharmacy and nursing. There's probably maybe one issue, but maybe it's an issue, Jessica, if the only reason you're ever on the floor is to investigate bad things, well, clearly you're going to have a reputation of being the bad person because the only reason you're there for bad things. So I would say, how about changing this around and start going on the floor to ask people about their concerns instead of only going to the floor to investigate errors. So I think we have to take that step back to change that. And I know you have the best intent in your heart, right? But we don't know what the nursing's dealing with where you work as one example of this when we walk to the floor. So I would say try to find other ways to identify risk, potential problems in these units proactively to get their buy-in and get that conversation started that way. And when they start knowing you're listening and buying into this potential stuff, I'm going to assume, Mike, that that intimidation factor may start melting away when they see you're there also to help them fix things, not just there to investigate. So I think you need a combination of, well, here's what we're doing to help you, and here are what you're saying, and the change we're going to make, and not be your presence only. I'm there to investigate. If that makes sense, Mike.
Yes, it does. I totally agree. And thank you very much, Matt, for a great program and for answering the questions. And we appreciate all of you who attended. If you do have additional questions that you'd like us to answer that we didn't get to, we have an email address, ISMPinfo, that's ISMPINFO, at ismp.org. That will go to our fellows and they will get to us and we will get back to you. But for now, thanks everyone for attending. And I'd like to thank again our colleagues at Novartis Pharmaceuticals in the name creation and regulatory strategy department. They take students from the area schools of pharmacy and also have a fellowship program. So we do a lot of interaction with them. And you know, this is a group that's really interested in promoting medication safety. We appreciate their support for allowing us to do programs like this. It is greatly appreciated. Well, thank you very much, everyone. And until next time, Mike Cohen, Mac Rissinger, and Jordan Rufo signing off. Thank you.
Thanks, everyone.